الرحمن الرحيم والحمد لله والصلاة والسلام على رسول الله. Again, welcome everybody. And as we said, we at the Saudi Society of Nephrology and Transplantation, we are committed to continue these educational events. I would like initially to thank the sponsoring company V4 Pharma for this events, and without the support of our colleagues in the sponsoring company, this is definitely not gonna continue. So one important thing I would like to say that this event is approved as 2 CME hours, and there will be no certificate will be issued. So the CME hours will be added to your account online by using your Saudi Council for Health Specialties number. The only thing, as you know, there was a change in the Saudi Council in their platforms or their websites for adding the CME hours. And today, alhamdulillah, we just get a message from them. It's been approved as the society is one of the platforms that can create create events with approved CME hours. So we apologize that the last 2 events we didn't add the people, but we'll work on it. We have your Saudi Council number, so we'll add all of you, inshallah, those who attended, of course. And this event again will add the people online, the 2 CME hours, once you are attended from the beginning until the end. I will not further delay. I will leave the moderator is Dr. Naif Abdul Majid. So the mic is yours, ya Naif.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah walhamdulillah rabbil alameen wa salatu wa salam ala ashraf al-mursaleen Sayyidina Muhammad. Good evening, everybody. My name is Naif Abdul Majid. I'm a pediatric nephrologist consultant at Prince Sultan Military Medical City. I'm very happy to moderate this webinar. In the first, I want to really appreciate what Saudi Society for Nephrology for her great effort in preparation for a serial educational webinar, even in difficult situations such this time. And special thanks for the V4 Pharma company for sponsoring this webinar. Tonight, it's a great pleasure to introduce Professor Jürgen Floege. He is the head of nephrology and clinical immunology division at the University of Aachen, Germany. Professor Floege is a former executive council member of the International Society of Nephrology, ISN, the European Renal Association, ERA, EDT, and KDIGO. He is one of the editors of the best-selling textbook, Comprehensive Clinical Nephrology. His main research interests involving both basic and clinical research, with more than 600 publications. So Professor Floege today will talk on one of the common issues in chronic kidney disease, which is hyperphosphatemia management. Please, if you have a question, you will find Q&A icon at the bottom of the screen. Just write your question. So go ahead, Professor Jürgen Floege, and the mic with you. Thank you.
Thank you so much. And, welcome, everybody. It's a great pleasure talking to you. And actually, one of the blessings of Corona is that I can do this without travel, although it would have been lovely to be with you on this, I understand, very historical day when you started your first space mission. And I hope everything will go well and you will be successful on this one. So without further ado, let me share my screen with you and tell you a little bit about the most recent developments in hyperphosphatemia management in CKD, which is a very common issue, of course. Actually, down here, you see my wonderful hospital, and it's a funny hospital, as you can see, not only from the outside. It's also funny because we're located in the very heart of Europe, And actually the hills that you see in the back here are already in another country. They're actually in the Netherlands. I can also see Belgium, which is right over here. So it's a pretty unique location for a large hospital. So these are my conflicts of interest. I have received lecture fees from Amgen, Bayer, Fresenius, and Velphoro. And this is my first take-home message. Serum phosphate in dialysis patients predicts all-cause and cardiovascular mortality in CKD. So we recently had a look at the so-called ARROW database. Essentially, this is a database of the European Fresenius dialysis centers. And we looked at the relationship between phosphate and mortality. And we found that the lowest risk, no matter how you adjust the model, the lowest risk is at a phosphate level of 1.08 to 1.8 millimoles per liter. I'm not certain if you're a milligram country, then please multiply by 3. And you can see that there's a linear increase in mortality no matter how you adjust in hyperphosphatemia. And there's also a linear increase in hypophosphatemia. And please note that this was adjusted for albumin. So this is not just malnutrition, it's something else. The same is true for calcium. What you can see here is that the lowest mortality is observed at a calcium total serum calcium below 2.16. And the notable thing in contrast to phosphate is that if you adjust for all the various factors, there's no real lower limit here, whereas mortality sharply increases in hypercalcemia. And you can see, for example, that at a phosphate of a calcium of 2.8, you have a doubling in mortality. So this really emphasizes the latest KDIGO recommendations that you should really avoid hypercalcemia, but that moderate hypocalcemia may be quite an acceptable thing. And finally, PTH. It's a U-shaped curve again. The lowest risk of mortality is observed between 260 and 720 nanograms per liter, pretty much similar to the famous KDIGO target range of 2 to 9-fold the upper normal limit of the assay. And you can see that it sharply increases at low PTH, when in all likelihood this dialysis patient would have adynamic bone disease. And it sharply increases above a PTH of 1000, when in all likelihood you have high turnover renal bone disease. Here's a study very similar from Spain. It's a study we did in another cohort. And here we did something else. We asked what would happen if the phosphate in the next month moves. So again, here's the lowest mortality. If phosphate increases, mortality increases. If phosphate decreases, mortality increases. But this is only true if your baseline phosphate is in a well-controlled range. If at baseline you have hyperphosphatemia, as many of my patients do have, and you increase further, mortality increases. However, if from hyperphosphatemia you decrease, you have a 20% reduction in mortality, and then it only goes up again at very low phosphate levels. So this is one of the few pieces of evidence. It's amazing. We have the year 2020, and we are still uncertain how much to lower phosphate. But this is one of the few pieces of evidence we have that lowering phosphate can actually improve survival. Take-home message number 2, phosphate additives in food affect laboratory parameters and bones, at least in mice. So in terms of phosphate, we have learned that you need to distinguish organic phosphate from meat, the chicken here, organic phosphate from vegetables, the beans or whatever this is, because this is absorbed in a different fashion. Organic phosphate from animal meat is relatively easily hydrolyzed, and you generate anorganic phosphate in the gut, which can be absorbed. In contrast, organic phosphate from vegetable sources is relatively slowly hydrolyzed because we lack the enzyme phytase, which can degrade this organic phosphate. So in a way, plant or vegetable derived phosphate is the better phosphate because it's much more difficult to release it. But the worst phosphate you can have, so the take home from this is that probably per gram of protein, a plant source in terms of phosphate is safer than an animal source. So here's one of the clinical studies that has tested this in a 7-day crossover study. It's a study by Sharon Moe in the US. And what she has done is place these healthy volunteers, GFR above 30, on a meat-based diet for 7 days, and then on a vegetarian diet for 7 days. You can see that the total phosphate intake, which was actually low, most of my people at least eat 1,000 milligrams or more. Here it was only 800. You can see that the intake based on chemical analysis was very similar. Phosphate in plasma increased a little here, decreased with the vegetarian diet. PTH didn't really change. FGF23, the key phosphaturic hormone, increased quite significantly with a meat-based diet and decreased here because you had to excrete less phosphate. And phosphate in the urine was lower here than there, very much similar to the FGF23 levels. They then went on in another study to 10 healthy volunteers, placed them on a 1-week diet of phosphate and no phosphate additives. And then a 1 week, sorry, this is German, I should say week, diet, same calories, same composition, but mostly processed foods. So the key problem that we have, and I assume you have it as well, is that many of us eat no longer food from the market, but food that comes from a deep freezer or is in some way processed. And again, what they found is that calorie intake was very similar. But if you look at this line, phosphate intake from the market food, let's say it that way, was 1,000 milligrams per day. From the deep freezer processed food was almost 1,700 milligrams. So it's a dramatic increase in phosphate. And as a sideline, the sodium intake also increased. It almost doubled from the processed food. So you can see that in processed food, you find a lot of phosphate salts and sodium salts that, of course, are easily absorbed by the patients. And finally, they did a study in mice and fed them for 5 weeks with a very low phosphate diet or a high phosphate diet. And then they put the mice into a CT scan and they looked at the vertebral microarchitecture, and you can see a nice architecture of the bone here. And all of a sudden it's fragmented when you eat high phosphate for 5 weeks. And I guess you can appreciate that the thickness of the middle femur here is much smaller if these mice are just for 5 weeks are placed on a high phosphate diet. I think this is a fairly dramatic example of what phosphate additives to food can do. So the take-home message here is that Plant-derived, vegetable-derived phosphate is probably relatively safe. Meat is in the middle, but the worst is phosphate additives, because phosphate additives are pure salt and they can be resorbed by 100%. Here's a nice illustration from the University in Michigan. The following items from McDonald's contain phosphate additives. And you go through this enormously long list. And they suggest that you should avoid menu items that consist of these foods. So when I look at this list and then look at McDonald's, and I guess the same is true for Kentucky Fried Chicken, for Burger King, for whoever you talk about, essentially all you can eat is the paper that the menu was printed on, but nothing else if you want to avoid phosphate additives. This is a typical problem of our current civilization, that we want phosphate additives for various purposes, because the meat should look nice and pink as a preservative, but phosphate additives are also in things that you don't even think about, like coffee whitener. There's a lot of phosphate additives in there to prevent clumping of the coffee whitener. Baking soda has it. Lots of things have phosphate additives. Take-home message number 3. High serum phosphate markedly accelerates calcification in hemodialysis patients, in particular if several things come together. And this is probably the nicest study to illustrate that. It's a study out of Turkey by Erkan Ok. And what they did is they took 425 prevalent hemodialysis patients with a lowish PTH, and they had all been dialyzed with what I would consider a relatively high dialysate calcium. They were randomized to a dialysate calcium of 1.25. This is my normal dialysate calcium, or a dialysate calcium of 1.75, which is what we tended to use 20 years ago or 30 years ago. And then these Turkish patients underwent a bone biopsy 2 times at baseline and 2 years later, and a spiral CT scan within 2 years. The authors were frustrated when they looked at coronary artery calcification, CAC score, because there was no significant difference between the 2 groups. When they stratified by phosphate, no significant difference. But look at the bottom panel. 3 groups are identical, but one group really sticks out. It is the group where patients receive calcium through the dialysate and where the patients are not well controlled in terms of phosphate. So the scary situation really is when you have hyperphosphatemia and when you have a source then of calcium loading. This is when patients really progress. And to illustrate what these bars mean, these patients, as you can see, the delta is about 300 score points in 2 years. Now, what does that mean? If you and I turn 90 years old, we may have a coronary artery calcification score of 300 after 90 years of life. These patients need 2 years to add 300 points. This is incredibly accelerated calcification by combining these 2 factors, and it certainly isn't a good sign for these patients. Take-home message number 4. We now have many phosphate binders, but many patients don't like them. This is because the daily tablet load in a dialysis patient is one of the highest of all chronic illnesses. A typical dialysis patient will ingest 19 tablets per day, or at least we hope they take it. Most of them don't. And you can see here from this analysis that half of the pill burden is from phosphate binders. Now, my patients, and I assume that your patients are similar, my patients count pills. They don't like to take a lot of pills. And the median number of tablets of phosphate binders that you need to ingest ranges from 6 to 9. Some cases even have 12 tablets of phosphate binders. In a study from Wales, they asked, why are phosphate binders not taken? And they interviewed 919 patients. 25 reported problems. 38 said, well, we forget them at least once a week. And the reasons for not taking them is, I forgot. The size is too big. We all know that phosphate binders are big pills. Dialysis patients have dry mouth, so they have swallowing problems. Many said these are too many tablets, or they have chewing problems. They don't like the taste, and I have no idea why some said not effective, because you simply have to eat more. Take-home message number 5. KDIGO now provides a stronger statement against calcium-containing phosphate binders. Here's something I wrote very recently, where I've reviewed all the available phosphate binders that we have today. They're all effective. They all bind phosphate. Otherwise, they wouldn't have been licensed. The pill burden is fairly low with aluminum. It's high with calcium, high with Sevelamer, low with Lanthanum, high with magnesium and calcium containing, and high with cholesterol, which is like Sevelamer. Pleiotropic effects, no here, no there. Sevelamer, I've coded this red and green. Initially, when Renagel or Sevelamer entered the market, we all heard about that. It's great that it binds phosphate and it lowers cholesterol and it lowers uric acid. What we didn't hear initially, what we've learned now is that it also binds vitamin D, it binds vitamin K, it binds thyroxine. So, of course, Sevelamer doesn't know what is a good and what is a bad effect. Lanthanum and calcium magnesium have no such effects. Cholesterol is like Sevelamer. Accumulation, maybe with aluminum. The old dialysis doctors amongst us know that most of the aluminum intoxication was from the dialysate aluminum. Calcium certainly is absorbed and certainly does accumulate, for example, in the vessel. Lanthanum, it accumulates. I will come to this in a minute. Calcium, magnesium, some accumulation. Cholesterol, no. Cost is an issue here. So the 2009 KDIGO guidelines said, we suggest, so it's a weak recommendation, we suggest to restrict the dose of calcium-based phosphate binders in the presence of calcification, adynamic bone disease, or if PTH is low. I never liked these guidelines. This was bad. And I didn't like it, and this is why I'm happy now, because it's stupid. You have to wait for the calcification to occur, and then you start acting. This doesn't make sense. You should act before the calcification occurs, because when it's there, it will not disappear again. So the 2017 guidelines simply state, we suggest restricting the dose of calcium-based phosphate binders. It's still a weak recommendation, but at least it's a stronger recommendation to really start avoiding them early. Here's a study that kind of challenged the whole field. This was meant to be a pilot study for a much bigger study comparing various phosphate binders. And what Jeff Block had done here is they gave patients with a GFR of 20 to 45, various types of phosphate binder or placebo, And then 9 months later, they looked at the coronary artery calcification, abdominal aorta or thoracic aorta. And much to their surprise, they noted that phosphate binders increase calcification. And in their conclusion, it says that phosphate binders promote progression of vascular calcification and that the safety and efficacy of phosphate binders in CKD remains uncertain. And they had argued that if you take a phosphate binder in the intestinal wall, all the phosphate transporters are upregulated. And this is why in the lumen you bind phosphate, but the phosphate transporters are upregulated so that uptake of phosphate really isn't much lower. This may be true. I have another explanation for you, and I believe it's a good one, and you have to go to the supplement to understand it. In the supplement, they give you an idea what is behind phosphate binder. And they actually tell you that there were 3 different phosphate binders: lanthanum, sevelamer, and calcium acetate. And I guess you can all easily appreciate that the only group where calcification increased was the calcium acetate group. It increased here, it was higher here, and it tended to be higher here. All the others were indistinguishable from placebo. So my interpretation of this pilot study is that phosphate binders are perfectly safe in CKD, but that it's not safe to calcium load patients with CKD. Here's one of the many large meta-analyses comparing sevelamer with calcium-based phosphate binders. And the take-home of these meta-analyses is very consistent, that there's a survival benefit if you avoid calcium containing and you give a calcium-free. All the meta-analysis only looked at sevelamer because this is where the most data are available. However, if you really look at the data that went in here, it is 2 studies from the same center in Naples where there was quite a dramatic effect. Other studies didn't see an effect like these. So it's still a little questionable. How about lanthanumcarbonat? This is a large Japanese study, lanthanumcarbonat and survival in Japanese dialysis patients. A large group, relatively speaking, and they saw that in the subgroup with hyperphosphatemia, the lanthanum group did better than patients receiving calcium carbonate plus sevelamer. So this would again argue in favor of avoiding calcium. However, the probability of cardiovascular events in an even larger Japanese study comparing calcium carbonate and lanthanum carbonate, no benefit. So there's still a degree of uncertainty here whether we really have to avoid calcium in phosphate binders. The new thing we have learned is that phosphate binders we had considered very safe induce problems. Here's new insight on sevelamer inducing funny gastrointestinal lesions. 19 cases, mostly with deposits of sevelamer in the GI mucosa, GI bleeding as the most common symptom, erosions, ulcera, and what is called pseudo-inflammatory polyps. And when you do a biopsy, you can actually detect sevelamer crystals in the gastric submucosa. And this is how one of these polyps look like, where the sevelamer has accumulated and forms these funny nodules. The same is true for lanthanum. You can see here these whitish spots all over the place. And when you look by microscopy, you can see that the lanthanum is deposited in here. and gives you this funny landscape. By the way, you can also monitor lanthanum adherence by simply taking an X-ray of the stomach, because lanthanum is so insoluble and it stays in tablet form forever unless you chew it. Something we often ignore in this whole discussion on which phosphate binder to pick is life expectancy. My typical dialysis patient is 75 years old, and the life expectancy of that patient is 1.7 years on average. Now, in that patient, very honestly, I don't care which phosphate binder I need. All I want to avoid is excessively high phosphate levels. And my main goal in these elderly patients is to have them eat and to be fit and to be happy. This is much more important than phosphate control. Yes, I get nervous when their phosphate exceeds 3 millimoles, but nobody today knows whether a phosphate of 2 is dangerous for a 75-year-old patient. The situation is radically different for the 20-year-old dialysis patient who I want to receive a kidney transplant and who I want to live. In that patient, I would do everything to avoid calcium, to make this patient not calcify, so that eventually my surgeons can transplant a kidney. And this is desperately missing from the guidelines. The diabetologists have learned this. They have different HbA1c levels for different populations. The hypertension guys have learned this. We still have to learn it. Take home message number 6, new iron-containing phosphate binders increase therapeutic options. We have 2 on the market now. The first is ferric citrate. It's effective. It has a high pill burden, like calcium acetate or carbonate. It has no pleiotropic effects. It accumulates. There is iron accumulation, which may be a good thing, but too much may be a bad thing, actually. Here's the phase 3 trial. Compared to placebo, it nicely lowered serum phosphate, and it was just as good as Sevelamer and calcium acetate in controlling serum phosphate over 1 year. This is ferric citrate and ferritin levels, and it's actually a surprising study. Until a few years ago, I've told all my fellows, dialysis patients and oral iron, forget it. You have to give it IV. This is not true for iron citrate. Now, the old people amongst us who still have used aluminum knew that you should never give aluminum binding containing phosphate binders together with citrate. What citrate does is it opens gap junctions between intestinal cells, and it allows the aluminum, or in this case, the iron, to enter the circulation. So it's really about the citrate component, why many of these patients have iron accumulation. And if you look here in the study over the 1 year, Sevelamer, no change in ferritin, serum iron citrate, quite a marked change in serum ferritin. And if you take a limit of 2000, you can see that there are many patients above this limit, and they are all patients taking iron citrate. So it is possible, and this is the conclusion of this editorial, too much of a good thing. It is possible to go into iron overload with ferric citrate. And the last one is sucroferric oxyhydroxide. I don't know who made up this name, sucroferric oxyhydroxide. It's a very difficult name. I don't like it. Velphoro, the trade name, is much easier. Effective, low pill burden. I will show this to you in a minute. Pleiotropic effects, a tiny little bit of accumulation, not comparable to ferric citrate, cost is of course high, as with every new drug. Sucroferric oxyhydroxide is very different from iron citrate because it's a complex structure. It's a structure where the iron is embedded in a water shield, and all this is embedded in starch. Now that has a dramatic effect. First of all, it is fairly resistant to gastric juices, and even at a pH of 2, the phosphate absorption from this compound is still high. But the most interesting thing is this one. This is an experiment I did with my youngest son. He loves doing experiments with me. So we took 1 pill of Lanthanumcarbonat and 1 pill of Velphoro, sucroferric oxyhydroxide. We put them both in a jar of water and we let it sit there. And then we took photographs. 10 minutes later, the lanthanum is still there, completely intact. The sucroferric oxyhydroxide has completely disintegrated. In fact, it disintegrates the moment you have it in your mouth because of the starch. So it needs very little chewing, which is a benefit for dialysis patients, many of whom have chewing problems. In fact, when we came back the next day, the lanthanum was still there. It simply does not dissolve. You need to chew it very, very well for the lanthanum to break it up and to liberate it. Here's the phase 3 study of sucroferric oxyhydroxide. It lowers phosphate just as good as Sevelamer over the course of 1 year. No big surprise here. The ferritin did go up with the sucroferric oxyhydroxide. Funny enough, it also went up with the Sevelamer, and at first we couldn't understand this. But then we separately looked at the US and Europe. And you can see that in Europe, Sevelamer also had an increase in ferritin levels. And the explanation is that this study was done when the American system changed from pushing EPO, pushing IV iron to bundling, when all for a sudden EPO pushing was abandoned and much more iron was given. This is why even with Sevelamer, there's an increase in ferritin, which was not observed in Europe and not observed in any other country. But what you see very consistently is that ferritin increased by 100 nanograms more in the Velphoro group, so that yes, you have a little bit of iron absorption, but no, it is much less compared to ferric citrate. Tablet burden. Sevelamer, 6.5 pills per day. Sucroferric oxyhydroxide, 1.5 grams. And that translated, this is grams. And that translated in a mean number of tablets of 3. So the simple advice to patients is take 1 Velphoro with your meal, full stop. Just 1, not 8.1 or any other large amounts of phosphate binders. The key side effect is gastrointestinal. And you can see here that diarrhea and discolored feces was much more common with sucroferric oxyhydroxide than with the Sevelamer. In fact, this cannot be true. This should be 100%. Being a good trial physician, I have taken 1 pill of Velphoro myself, and I can tell you that for 2 days after 1 pill, your stools are completely black. So it should be 100%, and you can monitor adherence. If patients say, my stool isn't black, they're not taking the Velphoro. But clearly diarrhea is a key side effect. It can, in some patients, it can be a benefit because many patients on dialysis tend to be constipated, if at all. Sevelamer causes more nausea and vomiting and more constipation. If you then look closer at diarrhea, you can see that diarrhea really clusters in the first 1 to 4 weeks, and then it kind of disappears. So it seems to be a transient effect, and you can tell this to your patients. Maybe this is because the intestinal microflora needs to adapt to the iron that you're now administering. We also looked at some interesting findings. We looked at what happens to the dose of oral vitamin D receptor analogs, and we checked PTH levels. And what you can see here is that if you are on an oral vitamin D receptor agonist and you just look at this one bar, all of a sudden the PTH goes up with Sevelamer. It decreases with sucroferric oxyhydroxide. If you look at IV vitamin D receptor analogs, no difference. So what does this mean? Well, it's an illustration of what I told you earlier. Sevelamer absorbs and binds some of the oral vitamin D receptor analogs and prevents them from acting on the PTH. And this is why the PTH increases, whereas sucroferric oxyhydroxide has no drug-drug interactions and thus seems to be safer. 1 year follow-up of this phase 3 trial, no difference in between serum phosphorus levels when you look at sucroferric oxyhydroxide or Sevelamer. So it works for a long time. And it's one of the few studies where we also had 100 peritoneal dialysis patients, and it also works in there. No big surprise, but nice to see. Here's real-world data. So what I've shown to you so far is study data. This is real-world. And what you can see here is the percentage of patients with well-controlled phosphate or badly controlled phosphate. And you can see here that in this patient group, phosphate control tended to be worse and worse as patients moved along. And then patients were switched to sucroferric oxyhydroxide. And you can see that all of a sudden this top group is getting smaller, the second worst group is getting smaller, and the patients with a well-controlled phosphate increase from 15% to 35% back after 1 year. So it works really well in real world as well. And I'm already at the end here. So what did I say? I said, and I hope I convinced you that phosphate control is likely beneficial. And I showed you the data that the source matters. Phosphate salts are worst, followed by meat, and the safest phosphate is probably from vegetable sources. And I showed you the Turkish data that if you have high phosphate plus calcium loading, you accelerate calcification. Phosphate binders, pill burden is a central problem. Calcium-containing phosphate binders, calcium-free is better, but consider your patient. I don't care in the 80-year-old. I just want them to eat and be happy. I care a lot in the 20, 30, 40, 50-year-old dialysis patient. Ferric citrate offers effective phosphate binding, has significant ion uptake with the possibility of overload, and suffers from high pill burden, 9 to 10 pills a day. Sucroferric oxyhydroxide, it's effective at every pH that we commonly experience. It has a very rapid pill disintegration. Remember the experiment I did with my son? There's low but significant ion uptake. There's low pill burden, 1 pill per meal. And I showed you that there's no drug-drug interaction, in particular when it comes to calcitriol, 1-alpha paricalcitol. That's all from me. Thank you for listening, and I'm very happy to answer any questions that you should have.
Thank you, Prof. Jürgen Floege, for the excellent talk about hyperphosphatemia. And now we'll, if you don't mind, we'll go to the question and answer. I have a question from my colleague, Dr. Khalid Saran, asking about this new drug, if it is approved to be used in children, the sucroferric oxyhydroxide.
It's not approved yet as far as I know, but I see no reason why it shouldn't be approved.
So it has been used in children or having trial?
It certainly has been used, but not in formal licensing trials as far as I know.
Yeah, as the Sevelamer. So I have another question from Dr. Khorshid. He asking, is it serum phosphate test? Is it enough for measuring the whole body phosphate?
No, because most of the phosphate we have in the body are in the bones, so you cannot measure it. It's almost as bad as calcium. In fact, serum is a really bad place to look for phosphate, and in particular for calcium. But we have no better means.
Good. So Dr. Ali also has a question that how does phosphate transfer from intracellular to extracellular fluid in chronic kidney disease?
Well, there are phosphate transporters, but I can't tell you about every single cell. In the intestine, it is several phosphate transporters which become very interesting and will become very interesting in the future because several pharmaceutical companies work on blockers of these phosphate transporters. This will be relevant in the pre-dialysis stage, where blockers are now developed that inhibit tubular uptake of phosphate, so you simply excrete it. And in dialysis patients, several companies work on blockers of the intestinal phosphate transporters, which may supplement the phosphate binder on the one hand, and then you also block the phosphate uptake by the intestinal wall. So this will be a very hot area in the future.
That's great, Prof. Jürgen. So I think we are at the end of the lecture. We answer most of the question. Dr. Khalid, he has a comment. Dr. Khalid, can you please? The mic is yours.
Yeah, thank you very much, Organ, for your wonderful talks and enlightening us about the new medications and other medication on the horizons. So just I would like to repeat what I said in the beginning. So looks like some our attendee didn't attend when I talk about the CME hours. So as I will explain it now. So our last two webinar, actually we couldn't added the CME hours online for the attendee because there was a problem in the website of the Saudi Council. They changed it twice. And today, fortunately, we received an email from them that it is now okay to be used and to add. So as we promise, all your CME hours will be added for the previous two webinar. In addition, also this webinar, all will be added online. There is no certificate, of course, just CME hours will be added online. And as we mentioned that our society is very committed to the educations, and as you know that all our previous CME, all our previous webinar was free of charge, and I'm very happy to announce that to see actually the number of the attendees today on webinars is 1,900, other than those in the YouTube is almost 500 or 600. So number of attendee is actually pressing on us that you should continue doing these webinars, and inshallah we'll continue on it. Last just announcement for our big conference that will happen on 17 until 19 of September. It will be full virtual Congress. It's about the critical care nephrology and hemodialysis, inshallah. Thank you very much. Thank you for your attending. Thank you, Organ, for your wonderful talk. And thanks, Nai, for your excellent moderation. See you, inshallah, with the next time webinar. And also, don't forget our upcoming Congress.
Thank you all. Bye-bye.